Hello, everybody, and a very warm welcome to our Life as a Clinician-Scientist, Nursing and Midwifery Symposium. We start by acknowledging country. We acknowledge the traditional custodians of the land on which we all meet and join from today, and pay our respects to elders past and present. And we extend that respect to Aboriginal and Torres Strait Islander peoples joining us today. It's important to remember that Aboriginal and Torres Strait Islander people were the nation's first scientists, and they remain the spiritual and cultural custodians of our land. Today, I'm joining you from Gadigal land of the Eora Nation, and it's a very beautiful day, and I hope the day for all of you across the country is looking good. So my name is Caroline Homer. I'm absolutely delighted that so many of you are joining today. I'm a midwife, came through a clinician-scientist background, and these days I'm one of the deputy directors at the Burnett Institute in Melbourne. So we're so happy to have you all. Some of you are very experienced as clinician scientists, as researchers in nursing and midwifery. Perhaps some of you are just thinking about it and wondering how to take those first few steps. And perhaps some of you are in the middle of it and wondering how to keep going or what to do next. And I really hope that our speakers and our panel today gives you some wisdom, some inspiration, and some great ideas to go forward. We know that clinical outcomes for our patients are better if they're cared for in a research-inspired environment. And there's plenty of research that shows that. And so we're here today to talk about the importance of research. So the program is online, and I'll leave this up for a moment. If you want to have a look at the program, please get the QR code there. There's also biographies. We're not going to read out everybody's biography. We have an amazing group of people with us this afternoon, and it would use up probably the whole of our time together if I read out all the biographies. We've asked particularly Trish Davidson and Christine Catling to give us 15-minute presentations. So there's a time for questions at the end. And then we have a wonderful panel presentation that I'll come to in a moment to explain how that goes. We have fantastic partners. Thank you so much to the Centenary Institute, Deakin, the George Institute, MCRI, the University of Melbourne, UNSW, and the University of Sydney as our really key platinum partners for the Academy. And of course, many other partners, gold partners and program supporters. A huge thank you if you're part of any one of these institutions and organisations, because it's your advocacy to your leaders that ensures that organisations like these on the slides come together and support the work that we all do. So just a tiny bit about the Australian Academy of Health and Medical Sciences. We are one of 5 learned academies in Australia, and we're the impartial and authoritarian voice of health and medical sciences. I'm a fellow of the Academy, as is Trish. We're an interdisciplinary body of 523 fellows, and we're elected by the Academy into these roles. And we do a lot of work, including convening experts from across Australia to address pressing health challenges. And one of those has really been this issue of clinician scientists that we're going to talk about today. Clinician researchers, clinician scientists, there's lots of different terms. So the Academy celebrates and strengthens research, influences policy, supports Aboriginal and Torres Strait Islander research and wellbeing, nurtures future leaders, and builds the Health Academy industry interface. And all of these aspects fit into nursing and midwifery work. And we are, so collectively, the largest provider cadre or disciplines in the health system. So we have enormous potential and enormous opportunity to make a difference. So just the program that you're joining this afternoon, Life as a Clinician Scientist, we held these programs across the country, sometimes face-to-face, but often virtually, because we find more people can get to join them. We've been doing this for 10 years. We've had more than 270 speakers over 37 events. So we really bring together people, hopefully to inspire you, to give you some good ideas, and to really strengthen that research leadership going forward. So I'm super happy to be able to introduce Professor Patricia Davidson. We know Patricia Davidson as Trish. I'm very fortunate to have known Trish for many years. We started out at St. George Hospital as nursing midwifery researchers. We did our PhD not long apart from each other, and Trish was one of the clinical nurse consultants and I was the clinical midwifery consultant at St. George Hospital. Seems like 100 years ago. Trish is a Vice Chancellor Fellow and the Interim Co-Director of the International Centre for Future Health Systems at the University of New South Wales. Her research is focused on individuals and families who live with chronic life-limiting illnesses, and she's been a leader in the US in nursing and obviously a leader here in Australia for many years. So we're super delighted to have Trish with us this afternoon. Trish, I'm going to stop sharing my screen and hopefully you can share yours. And if you just go into...
yeah, I think, can you see my slides now?
It needs just to, that's it. Perfect now, Trish. Perfect.
Thank you. Thank you. Well, firstly, thank you, Caroline, for the very warm and generous introduction and for the opportunity to speak with this esteemed group today and many people online. And also want to thank the Academy for their important advocacy for improving the health outcomes of Australians. I'm over the next 15 minutes, I'm going to talk about my journey as a nurse and a researcher. And I separated the two intentionally because I think for many people starting their career or thinking about being a researcher, you see people like Caroline and I and Kate and others and Christine on this panel and think it's been this linear path where it's all been mapped out. But for many people, it's a journey. And so what I want to do over the next 15 minutes is talk about some of the lessons that I've learned along the way. I also like to acknowledge the traditional owners, and I'm joining you from Gadigal country today. So I'm going to talk a little bit about my career trajectory, identify some sliding door moments, and I think this is important in embracing opportunities. Talk to you about the power of mentorship and sponsorship. And if I can indulge you with some of my reflections for developing and evolving as a clinician scientist. Well, this is where my nursing career began, actually nearly coming up to 50 years ago, which is hard to believe. I trained at Wollongong Hospital as a diploma nurse. And, you know, and I like this picture because it is a picture of Wollongong from those days. And I think symbolically, it's in many towns, hospitals are big buildings, commonly on hills, which create a whole lot of other obstacles, but really speaks to people coming to hospitals rather than nurses going out to the community. This is a real image of a graduating class, and thankfully nursing no longer reflects this sort of white monocultural image, and nursing now reflects the cultural pluralism of Australia. So nursing has changed immensely over the last, during my time as a nurse, and many of these changes have been for the better. A lot of my work has been in heart failure, and I'm just going to really put this up as a context of, often it's really important to identify a field that is prevalent, is costly, and makes a big impact on society. So heart failure over the course of my 50 years as a nurse has become an issue of great concern. When I started working in cardiology in the 1970s at Wollongong Hospital, people debated whether they would let 60-year-olds into the coronary care unit. Now we know in most critical care units, the average age of patients is around 76. This was an era pre-thrombolytics, pre-cath labs, and many people died of acute myocardial infarction. And so much has changed. So in my career in cardiology, we've gone from this very acute focus on the coronary care unit to seeing cardiology and cardiovascular disease as a chronic illness. What I have seen along my career is rapid technological innovation and progress, and I think this speaks to the power of science. Heart failure, when I started working in the area, many people died of acute heart failure without any treatments. And we were actually, as depicted in this picture, often subservient to physicians in our decision making and were the expert, and really patients were passive recipients of our care. But in spite of all of these technological innovations, what we've also seen across the course of my career is widening inequalities and huge disparities. Now, I've just put this up here as an example of how treatment has changed. And the reason I use this example is for the younger scientists here today. When I started working in cardiology, this was treatment for acute heart failure, rotating tourniquets. Now, I did a presentation for cardiology fellows at North Shore last year. And when I put this up on the slide, I think they thought I was talking about voodoo. But in fact, this is a paper from Circulation in 1974, because that was all we had to treat people. Now we know for management of heart failure, there's this huge armamentarium. So technological innovations and science has really advanced care for a range of conditions, particularly cardiovascular disease. Now I'm going to sort of switch gear to talk about, my journey into research. And I probably also was always intrigued by science, also saw the importance of improving care. So one of my jobs I had as a heart failure nurse was I was the clinical trials nurse for the Australian-New Zealand carvedilol study for beta blockers in heart failure. This was one of the first studies internationally to demonstrate the efficacy of beta blockers in heart failure, because previous to that, they were contraindicated in heart failure. So when this trial was unblinded, many of the patients actually came to me and said, look, I feel such a fraud because I thought I was doing so much better. And these were people on the placebo arm. And when I went to the big report outs of the clinical trial, people talked about this placebo effect. But I thought, look, no, this is not a placebo effect. This was about the effect of the nurse. This was about the effect of care coordination, of optimizing self-management, of promoting adherence. And so I started to think about how I could evaluate nurse-led models of care. Now I'm going to talk about a sliding door moment and also the importance of sponsorship. Dr. Warren Walsh was the clinical investigator, the principal investigator of this clinical trial, Prince Henry Hospital, which is long gone, and so you'll know how long ago this was. And he called me into his office one day, and he was not very warm and fuzzy in the clinic. And I thought, when I was called into his office, I thought, gosh, I'm in trouble. I'm probably going to get the sack. And he just looked over his glasses and he said to me, you need to go to the American Heart Association meeting. And that was a big shock to me because, as a nurse, if there's milk in the tea room, life is good. If there's leftover pizza, you're in heaven. So the fact that someone was willing to send me overseas to a conference was amazing. And it was there in the American Heart Association meeting in Atlanta that I saw Kathy Draker on the podium. And in these days, nursing for the Cardiac Society was not part of the main meeting. We all met on a Sunday. But here was this person who I didn't realize at that time was a nurse, who was talking about acute coronary syndromes. But what impacted in my mind by her presentation was how person-centered she was. And I looked down on the program and she was a nurse. So I reached out to her. Coincidentally, she came to Australia as a Fulbright, and she has been a mentor for all of my career. And I think in my PhD thesis, I wrote, Kathy Draker is the sort of nurse that I want to be, because even though she was a very accomplished nurse scientist, she was still actively clinically engaged. So my point of this sliding door moment is the importance of sponsorship, that we need to not only believe in people, we need to provide them with the resources to do things. And so I'm also very thankful to Warren Walsh. And then also the importance of mentorship. And I've had many mentors in my career, but I just think for everybody, you need to think about mentors, and maybe not just one, but to have a panel of these. So with a lot of people's support, I actually went on to, as Caroline alluded to, at St George Hospital, did this randomized controlled trial of heart failure rehabilitation. And again, this was about challenging assumptions, breaking new ground, because previous to the 80s, heart failure was a syndrome which was treated by bed rest. So the fact that people were exercising was a big challenge. And I was very fortunate to get NHMRC funding for this. And I think just being in the right place at the right time with an amazing mentor, Jill Coburn, who sadly passed. But again, an interdisciplinary collaborator who extended my clinical nursing to think about clinical care in a different way. Then I think the other important lesson is to always learn from our patients. And taking care of people in the community with heart failure was very different in the hospital. And what I soon learned was that this is the place where the majority of people die, in hospitals away from their families, but that's not where they want to be. So again, that was another opportunity for me to start to investigate how we can improve the care of people with life-limiting illnesses. So it was great that Caroline mentioned the clinical nurse consultant role, because I think being a clinical scientist is really the clinical nurse consultant role at a different settings, different speed, because the domains of the clinical nurse consultant role, research, policy, practice, and education, are really the core pillars of being a clinician scientist. And the trick is for people, particularly early in their career, is making everything count and link between those domains. The other point that I thought might be useful for people to hear about is leveraging a conceptual model. And I know as nurses and midwives, often people do convolutions, often in the last weeks of their PhD, of saying, I need this conceptual framework. But a conceptual framework, I think many of us have thought of it as nursing theories, but it's really an organising framework. So for many years, I've been a devotee of the chronic care framework. This was developed by Ed Wagner. And this was kind of a bit of a anchor for me, because if people would ask me to do things that didn't fit within this model, that's when I knew I was straying from what my core purpose was. But to me, this speaks to the importance of that has happened in my work, that people and their families and communities are the centre, that we need to have links between our healthcare organisations and the community. But without a positive policy environment, without funding and workforce models, we're never going to really improve outcomes. So as I start to sort of wrap up a little bit, I'm just going to give you some things to think about. Stand for something and live your values, even when people challenge you. And there have been many examples that we can discuss later where I've felt that, my values have been challenged, even in terms of promoting shared decision making, making the patient centre of care. Look at where you can have the greatest impact. The big thing is to create a program to demonstrate coherence of your work. A single project is not going to make you a clinician scientist. To be a clinician scientist, you have to be clinically credible. That means actively engaged in the clinical environment. That doesn't mean that you have to work 40 hours a week, but you need to be present and engaged in the clinical environment. You need to make sure that you engage in rigorous science, network, and also be engaged with people who can make a difference. And you need to be able to ask tough questions and see them through. And how do you make this happen? Well, I think these are, if for people who are wanting to make a career as a clinician scientist, these are the things that I would recommend: creating interdisciplinary networks. And one of the things that I've learned is that even though I am a passionate nurse, or have always had RN on my business card, always identify as a nurse, often I talk less about nursing, but more about patients and their families and communities. It's more effective because only people on this call really care about nursing and midwifery. Many other people care about what happens to individuals, families, and communities. Make sure that you have strong policy and practice connections, and also make sure that you have a global perspective, because this is important in really making a difference in the world. So some of the lessons I've learned is that you need to be resilient and tenacious. Time is your most valuable asset. Community capacity, mentorship, and sponsorship are critical issues. You need to find environments that are supportive and enabling, and if they're not, keep moving. And I think if you're doing meaningful work and having fun, it doesn't become tiresome. But as I mentioned, it's not always easy. And I just thought I'd share this quote from Deepak Chopra of turning a personal crisis around. And often you're going to have many challenges, many dark times in a research career, because if you're breaking new ground, if you're working in interdisciplinary setups, it can be challenging. But I think it's really important that you look at these, what you see as a crisis, to really transform these challenges into opportunities and move forward. The other thing that I really wanted to leave you with was, if, being a successful clinician scientist is fundamentally about not only being an expert clinician, but also your ability to think creatively and to lead. And so I was really impressed by this slide from the World Economic Forum that shows that, domain-specific skills are probably not going to be as important, particularly in the era of AI, but the power of analytical thinking, be able to think creatively, are going to be really important skills. So I think the other thing is that I swatted for my statistic exams. I left those exams thinking I need to make enough money to pay a statistician. So, I'm never going to be the best in terms of complex analytical modeling, but I work in teams where those people can do a great job. And then I'll just leave you with just thinking about your self-management. And I have often taken to these affirmations or these guidelines to help me repivot, particularly, in times where there are failures. There's not many jobs where you sign up to only be successful 10 to 15% of the time, which speaks to probably success in NHMRC funding. So you have to make sure that you are looking after your mental, physical, spiritual, and emotional health. And I'll just leave you with a quote which has continually inspired me from my career, from Letitia O'Donoghue, sadly passed just recently, phenomenal Aboriginal nurse. And she said, I was at a talk and I remember these words: socially created problems can likely be socially transformed. So I think many of the interventions that we do as nurses and midwives speak to the importance of social determinants of health, as well as biological and physiological mechanisms. So as we enter this era of personalised medicine, personalised health, where there's a lot of discussion of genetics and genomics, we have to remember that 40 to 60% of health outcomes are ascribed to the circumstances in which people are born, live, and die. And so I think that's a real powerful opportunity for nurses and midwives to do meaningful and impactful research. Thank you, Caroline.
Trish, thank you so much. That was just wonderful. And I loved so many parts of your talk, particularly the mentorship and sponsorship, the sliding door moments. I love the conceptual model. And just one quick question, which is how, I like the slide that you had asking tough questions. And how did you work out in the early days, what were the tough questions and how to study them? What was the sort of trick that you just came up with?
So, I think it's really about resilience. And I do actually have a moment where, being a nurse and, it was a novel thing for nurses to do research, and particularly nurses to get NHMRC funding. So I was asked to present at Grand Rounds at St. George Hospital. And I talked about quality of life and I got pounced on, literally pounced on. Now in every discipline, people think quality of life. Yeah. But it was like depression. And it can be, pretty annihilating because, we all have an overabundance of self-doubt and imposter syndrome. But I think that day I walked back from that Grand Rounds feeling really devastated, and the patient and their family ran up to me in the corridor and they said, "Thank you." And I said, "What?" You think, "What?" "Oh, you were so kind to my father yesterday." And I think, no, I was just doing my job. I didn't even remember them. So I think if you keep patients and their families the center of what you do, I think it gives you strength and stamina to take the knocks. And there are knocks, particularly, and they're still there for what is assumed to be softer sciences.
Perfect. Thank you. That's just wonderful. Thank you so much, Trish. We really appreciate you being with us this afternoon. It's a huge honor to have you speak to us. So thank you very much. All right, I'm going to share my screen again, and I shouldn't have unshared it, should I? Because I was doing so well before. How does that look, everybody? And someone?
Good. Yep.
Is that okay? What has happened is I've completely lost everything.
So we can see the slide with Professor Christine Catling's name up.
Yeah, you can see the slide, but so just bear with me for 1 second, everybody. Really sorry. Oh gosh, don't you love this? Now it's completely gone. Anyway, I can make up Christine's introduction, having been so let's do Christine's introduction, because I can tell you about Christine. Christine is the Professor of Midwifery and has a clinical chair at Royal North Shore Hospital. She also has an appointment with UTS as a professor. And I'm fortunate as well to have known Christine for a very long time. We worked together at St. George again all those years ago, and Christine did her PhD with me before moving into academia. So it's a real privilege and pleasure to welcome Christine today, and she's going to share her slides. Christine's also joining us at 6 o'clock in the morning from the north of England, so you're doing very well to be bright and awake, Christine. Over to you.
Thank you. Does my slide look okay? Hopefully you can see it okay.
Yep, they're great.
Yep. Oh, good. Okay. Thanks, Caroline. So I've had an introduction. Thank you. Thank you for doing an off-the-cuff one there. Now, a lot of eminent people have spoken about this topic before me, but I'm very happy to give you my perspective. So thank you for inviting me to talk today. I'll talk about what my role entails, but I do want to say first and foremost that in this role, it is such a privilege. But actually, I really do prefer the term clinician researcher that I've got up here. It feels better to me, especially as I've got a brother who's an astrogeologist and a son who's a physicist. Anyway, that's just me. So I'll get going. I am going to talk about my journey and a little bit about, what we've done, what we need more of, where it could lead to. I'm going to touch on the reasons why clinician researchers are important, but I think you can all understand this already, and I think Caroline gave a good overview of what that really entails. Also give some practical examples of how clinicians and research can go really well together. Now, I was told I was going to be really busy in this role because I've only had the role for just over a year, and thank you, Caroline, you were right, but it is really quite a great kind of busy, and I'm loving it. So this is just, I think, reiterating what Caroline had said. I've been a conjoint academic, like I say, for just over a year, contracted between UTS and Northern Sydney LHD, roughly half and half through the week. It's thrown me into a very active research workplace, and these points on this slide are, pretty obvious. There's lots of research that shows that reduced mortality, the higher quality of care, the better patient experiences, cost efficiency, cost effectiveness and efficiency, benefits to staff experience and recruitment and retention, which has been really the focus of my work for the last 5 years or so. The CEO of Northern Sydney is extremely interested in research, which is really, really great. In fact, he has an aim that every person who comes into the hospital should be offered participation in a trial of some sort, which is quite ambitious, and I love that ambition. It's also not rhetoric, just rhetoric. He's actively employing conjoints. We have me for midwifery, there's one in nursing, there's one in mental health and drug and alcohol, and a new critical care professor just about to be appointed, and I believe there are plans for more in the future, which is fantastic and quite unusual, I believe. So my trajectory, now I trained in the UK as a nurse and a midwife at the Norfolk and Norwich Hospital in the middle of Norfolk in the UK. So that picture on the left, that beautiful building, dates from the 16th century. The nurses' home is just to the right, and again, that was one of those beautiful 16th century buildings that I had the privilege of being in for a number of years while I did that training. I say training because in those days there were no degrees. Obviously we were educated, but it was very much a mentorship role in the hospital, training as such. So both nursing and midwifery. Came to Australia in 1994, worked for 15 years or so at St George Hospital. Everyone here seems to have been working at St George Hospital so far. Great place to work as a clinical midwife. So that's that picture in the middle. And that really shaped my idea of what midwifery was like in Australia, because I'd obviously come from the UK. There were lots of parallels, but lots of differences as well. So I had to sort of get my head around that. While my kids were really little, did a master's degree, then did some clinical midwifery consultancy work. So it's sort of quite reflecting what Trish and Caroline have just mentioned. And then research assistant work at UTS. So eventually sort of moved to UTS. So that's the picture at the bottom with the 3 of UTS crazy buildings. And then as the kids got older, I was able to work full time, as prior to that only part-time was the only option I had really. Just a little bit of bits on the left of the screen there. Just one of the roles I've had for a while and still have is co-directing the Collective for Midwifery, Child and Family Health. This has got a really long history of supporting HDR students and also other staff working in roles related to the disciplines and not just in midwifery. So that's been a joy and such a long-term thing. Now at Northern Sydney, as well as my current HDR students, I picked up a couple more PhD students and a master's student, so I'm going to be pretty busy next year. These are clinicians who have just sort of almost been waiting for somebody to talk to about their ideas. So this is another benefit of having somebody in the workplace in the role that I have, which has been great. So I've nurtured these people, put their proposals in, so see where that goes. And honestly, as part of my work as an academic, that is the thing that gives me the most joy, is to nurture and support people through to the fruition with their research degrees. Now the picture at the right are pictures on the right, Royal North Shore and Hornsby Ku-ring-gai Hospital at the bottom. We'll soon be adding Northern Beaches to the suite of Northern Sydney local hospitals that have maternity units, which is going to be great. So I'll be adding even more travelling to my week. So just an overview of that. Those two hospitals have about 8,000 births a year. Royal North Shore is one of the highest level maternity units in New South Wales, a level 6. It's a major tertiary teaching referral hospital for Northern Sydney. Has links with Macquarie and Sydney Uni for medical education, and mainly UTS for undergraduate and some postgraduate courses for nurses, midwives, and allied health as well. Now, don't laugh at this, but this was me as a student nurse before midwifery, probably about 18 years old, a bit grainy. Yes, but like I said before, it was a hospital-based training, and it was very rote learning, fact-based, and practice that was expert-led, not evidence-led. Research was really not mentioned much within the training that I had. So I've had quite a journey into the role that I'm currently in. So in this role, I guess the benefits for Northern Sydney LHD, and I won't go into this to depth, but I will talk about these things. And before I say it, there is only about 15 midwifery conjoints around Australia, I believe. Zoe might have the better numbers, but it's not many. When you look at what our role is and what we can bring, you know, it really is quite substantial. So evidence-based practice, I help to integrate their latest research into clinical care, bring it to the attention of the workplace. They're too busy with their clinical work to read papers and keep up with things. So somebody in my role, this is where I can really contribute. Helping staff to identify gaps in care. They often know them already. And then supporting staff to lead those quality improvement, usually starting with a QI project. But some have even already just sort of started their own research project on their own, which is amazing. I'll talk about that one in a minute if I've got time. Helping with funding, you know, hospitals with active clinician researchers more likely to attract research funding and academic partnerships. This obviously boosts the institution's reputation and can lead to higher rankings and recognition. So that's a great thing. Just getting staff on board, providing mentoring during those projects, these opportunities, or letting them know of the opportunities, you know, like what conferences are going on and all that sort of thing. But those opportunities for research or being engaged in research with clinicians at the coalface can really improve their job satisfaction and, you know, hopefully reduce burnout. This has been my focus of my fellowship for the last few years, about burnout and midwifery. I don't have time to talk about that, but the other thing is economic benefits. You know, those research active hospitals have those better patient outcomes at lower costs. Again, that's been mentioned already today. And then the sweet spot of clinician research is contributing to health policy development and system level change, and that's where we all want to get to, isn't it? Many clinician researchers have a dual role, and some have an element of clinical work. I don't with mine, but having been in the role for a little while, my main thing has been making sure I'm visible and getting people to know me, getting me to know people at the coalface, all the executive team, the managers. So it's been a whole different workplace, and it's not just a small LHD, it's quite a large one. So that's been fine, but quite challenging. You know, also making staff feel comfortable to talk to me about their ideas. You know, I have been quite proactive in visiting wherever midwives are going to be. I'm going to be there too. So attending ward meetings, celebrations, events, where they're going to be, showing my face, talking to as many as possible. Like I said, they're the ones who see the issues in the workplace, but also regularly meeting with managers and the executive staff. Again, they see where the issues arise, and then they ask me to help find creative ideas or creative ways to tackle the issues. The other thing that I have revamped, the MIC, the Maternity Improvement Committee. This was a sort of had lost its traction, so it wasn't really taking place for a while. So I basically changed the time of it, changed the venue, and now it's pretty well attended by midwives. And we go through the projects that are ongoing, people's ideas, the QI projects and seeing where they are, where they need support, and move them forward. Basically, we've introduced a bit of a journal club as well. Again, like I say, clinicians do not have time to read journal articles usually. We've just a really quick, like half an hour, that's all they have time for often. essentially what that study was, what it meant and how it affects midwives. We recently done the Big Baby trial. Of course, that's a big one out this year, which was great. And we really talked a lot about that one, brought a lot of interest into the room. Just a good example of this project. I came later to this project. It had already been put together and carried out to some degree. I did help write the paper that has been submitted now. This was about virtual reality. So the executive actually identified that there were severe perineal tears that were higher than the New South Wales average, and they said they got funding secured. They got a VR company involved, put together these VR modules to standardise practice about perineal care. And I can't remember the percentage, but I think it was something like 80% of obstetricians and midwives did the VR modules, and of course standardised the practice, taught people, what they were supposed to do in relation to the bundle. Rates came down. We've got other practice-informed maternity research at New South Wales, things like study of the positions women take in second stage of labour, relating it to epidural use, perineal outcomes, skilling up midwives to insert Foley-Leaguer's catheters for inductions of labour, minimising blood loss for neonates. I just wanted to show off the birth room in Royal North Shore. There's some beautiful 9 birthing rooms, all with beautiful natural light. 8 of them have these beautiful bathtubs allowing for water birth, and it's got a less clinical feel, which really does help women labour better. And I'm actually another QI project that I'm hoping to support soon is to enable midwives to actually use the features in this room a little bit better, because over the years, these were put together in 2014, I think. So I think the features are underutilised at the moment. So that's one project that's going to be up and coming. Just a list of collaboration and how important that is. Bringing people together, and having been in academia for a while, you do get to know a lot of other people's work. So another practical example of how I helped at Royal North Shore for that, we had issues with the new graduate midwives at MGP. I was aware that a colleague at University of Newcastle had put together some workshops, so brought them to Royal North Shore to help those new graduates integrate into that very wonderful midwifery group practice model. We also have that wonderful collaboration between Northern Sydney and UTS, and that's been ongoing. We meet together quite a number of times each year. And then these are just some of the networks that I'm part of, as well as other things like the Maternity Alliance with the New South Wales Midwives and Nurses and Midwives Association. I chair the Australian College of Midwives Midwifery History Committee. I'm on the Northern Sydney LHD HREC, which is quite interesting. I also lead the practice pillar of the Planetary Health Collaboration for Nurses and Midwives, which is a pleasure. This is just a snapshot of 2024 for nursing and midwifery, the annual report. So you can see we were quite successful in lots of these. Now midwives will comprise a small proportion here, as nurses vastly outnumber us in the LHD, but we will be catching up next year. These are the things we need, and I think I might have run out of time, but I just want to say, if we support our health workforce to enable them and role model an evidence-based, research-engaged workforce, it is a retention strategy, and creative ways to retain our health staff is paramount right now. We know this has already been put together by the wonderful implementation science people at Sphere, mapped it all out. We just need to get it happening in more places. I don't think I've got time to go through these. Have I, Caroline? No, you're smiling as if, yes, no, okay, won't do that. But this is just my kids. So just keeping it real, balancing, understanding your ducks are not always going to be in that row, asking for help when you need it. Like Trish said, centering the person, centering the woman in all you do, be kind and follow through. So thank you for that. I'll stop there.
Christine, thank you so much. That was just wonderful. And I really liked how you explained your newness in the role and how you've started making things happen and making change, because I think often we see these roles as, you know, people have been in them forever and they seem to do it all seamlessly. And I really liked that you'd been thinking about things and changing things. That was great. And I loved your practical examples and collaboration. So that's super helpful, I think, to people. There's a question I just wanted to ask you. There's a few questions, but I'm just going to bring them together and ask you what you think about using quality improvement in health systems as a mechanism into doing research, and whether that's been something you've seen even in your first year in the role.
Well, I think it just gives people a taste of what it's like. There's not all the massive ethics applications and all the sort of bells and whistles around a research project, but QI projects can be amazingly powerful, and they can change practice in just a simple audit. You know, so that is inspiring in itself. If you see the pain point, you see we could do this differently. Let's do that, and it fits the brief of a QI project. They're not a lesser thing at all to research. Obviously, research can go crazy, but QI projects can also be incredibly powerful and effective. And then I think it can spark that interest in research, and then with the right support, of course, the clinicians with the right people around, such as clinician researchers in the workplace, we can go everywhere with them. So I believe that it's a great start to research. Yeah.
Right. And I think you touched on there the importance of collaboration. And I think Trish also talked about collaboration and mentors and supporters and champions. And I think that's a really nice theme across both talks. Christine, thank you very much, and for showing us your photo as an 18-year-old student nurse. You look just the same, just different
Oh,
coloured
so
hair.
cute. Yeah, thank you.
I know you're off to your conference in the
Yeah.
UK, and thank you for joining us really early, and we really appreciate your time today. All the best.
No problem. Thank you.
All right, so that's our wonderful keynote presenters. I think both of them gave us such wonderful food for thought. We're now moving on to a panel, and I'm really happy that Dr. Karen Davies is going to moderate the panel. Karen has worked as a clinical nurse consultant in hemodialysis and safe medication practice for 31 years. She's currently a conjoint as a clinical research fellow with Queensland Health, the Hurston Infectious Diseases Institute, the University of Queensland, and she's also the CNC for safe medication practice at the Royal Brisbane and Women's Hospital. What a wonderful collaboration, Karen, all those groups to bring together. So fantastic to have you with us here today, and I'll hand over to you now.
Thanks, Caroline, for the introduction. It's now my pleasure to introduce our four panelists that will be joining us, and we get to ask them some questions about their life as clinician scientists. First of all, we've got Associate Professor Evan Alexandrou. He's a Clinical Associate Professor of Nursing at the University of Wollongong and a Clinical Nurse Consultant in the ICU at Liverpool Hospital. He leads the Central Venous Access Service there. He's a founding member of the Australian Vascular Access Society and contributes to clinical education, research and advancement in vascular access across Australia and globally, and he's renowned in that field. Thanks, Evan, for joining us. Then we've got Associate Professor Zoe Bradfield. It's an Associate Professor of Midwifery with a joint appointment between Curtin University and the Women's and Newborn Health Service in Western Australia. She's worked as a nurse and midwife across a variety of rural and metropolitan settings, and her research explores the social, clinical and systemic conditions that influence maternal and infant outcomes. So thank you, Zoe. We've also got Professor Kate Curtis, AO. She's an emergency nurse, and her translation research program focuses on improving the way to deliver care to patients and their families. Professor Curtis is the world's most published author in the field of trauma and emergency nursing, and is an expert at leading change and implementation in complex clinical environments. And Kate still does night duty as well. And we also have Professor Della Forster. She's the Director of Midwifery and Maternity Services Research Unit at the Royal Women's Hospital in Melbourne, and a leading international researcher in maternal and infant care. She has an extensive experience as a clinical midwife and specialises in research about maternity care, perinatal, mental health, and the maternity workforce, and has a focus on improving how maternity care is provided, particularly for socially disadvantaged populations. So we've got a great panel here, and there are some questions that are lining up already to be asked. But what we'll do first of all is I'll kickstart some questions off. So I'll open this up to all of you. What first inspired you to pursue research alongside your clinical career? Is there one of you that would like to start that off?
I can, if you like.
Okay. Thank you, Kate.
Thanks. Is the volume okay?
Yes.
Yep. Basically just wanted to change things and couldn't change anything without numbers and evidence. And even though I actually did get kicked out of the research subject at uni as an undergraduate student because it was really boring, and didn't quite understand why we needed to know this rubbish, it needed to be turned into something meaningful to make change. So that's why I did it.
Thanks, Kate. Stella?
I suppose I was always really, really interested in the why we did things. I was always probably the pesky sort of, when I was a student midwife, the pesky student midwife who was sort of questioning why, and I didn't why that, and I don't agree with the way you're doing that. So I suppose I was always extremely interested in the why, and right from early on, probably less so in nursing, but once I became midwife, early on going home reading articles about why we, should we be cutting a episiotomy or not, or, so very interested in the why. That really got me sort of started, and then sort of gradually sort of got into a research career. Yeah.
Thanks, Stella. Zoe? Oh, Alex, Evan? You got your mic off?
I guess for me, it was identifying particularly evidence practice gaps that sort of led to complications, and looking to find solutions in that sort of area. And the only way you could do that and then gain momentum and adopt change was with science and with being able to research. So that's how I sort of started down that track. But probably the other thing too for me was being in an advanced clinical role where we were sort of, at the forefront of sort of nurse-led advanced practice. For me, it was also that science invalidating what I did. And so a lot of my earlier work was around validating advanced clinical practice, and still now in terms of techniques and what we do.
Thanks, Evan. And Zoe?
Look, probably my motivator is a combination of things already mentioned. I got bitten by the bug quite early after my doctorate, and really realised the capacity for research as a vehicle for cultural and clinical transformation. I was privileged to work in some multidisciplinary research teams, and even early on to lead multidisciplinary research. And there was in that a metaphor for what we really wanted to reproduce in the clinical environments, but were struggling, where we could work harmoniously and together, mission-aligned research in multidisciplinary teams, and yet there were rub points in the clinical area. So to use research as a vehicle for that clinical and cultural transformation that needed to occur in order for us to embed evidence-informed practice and improve outcomes for the people that we serve. So that was probably my motivation.
Wonderful. So the next question is for Zoe. For nurses and midwives who are curious but unsure where to begin, what would you say would be the first steps into research?
Yeah, it's a really good question, and I probably spend at least 15% of my week speaking with clinicians about this, and it echoes what Christine was saying earlier, in terms of clinicians are waiting for someone who can really resource them around this, because they are curious. They want the agency that comes from, you know, evidence information. And so I spent a lot of time speaking formally and informally with clinicians about how to do this. The reality is a really nice, easy, simple step is something that Caroline mentioned earlier in terms of quality improvement, is a really nice entry level mechanism. And it's also often done in groups. And so there's safety in numbers. A quality improvement activity is often, you know, a group of clinicians in a particular clinical area wanting to ask, why are we seeing these trends or patterns emerging, or why have we got this intractable problem, and how could we find a solution to solve it? And so there is that kind of joined up, shoulder to shoulder, let's fix this problem kind of approach. So clinical inquiry and quality improvement activities are a great place to start. Another thing that I encourage midwives and nurses to do is to really optimize and realize our knowledge. Often we diminish the fact that we haven't had a lot of research experience in our entry to registration programs, but actually what we bring to research teams is something that many other clinicians don't have. We are implementation specialists, so we know right from the get-go whether a recommendation will or will not work. And we can spot flaws in an implementation plan a mile away, because we're often the ones that are at a grassroots level, at an operational level, tasked with implementing a new evidence-informed solution. And so our ability to detect things that are pragmatic and that won't, because they're not pragmatic, or they require too much extra work on behalf of participants or clients, you know, we are really useful for those things. And when we are brave enough to speak up within research groups, our contributions actively contribute to the success of projects, of research projects that might be being led by another clinician, but that bring our insights as implementation specialists. So I guess being brave enough to value the skill set that we come with, even if they're not highly developed research skills yet, what we have as grassroots clinicians really makes successful research programs. We're public health experts, and we are expert gate openers. The quickest way to, you know, to find a way to open a gate is to tell a nurse or a midwife, no, or that can't be done, or that patient can't be seen, or that, you know, we can't find a solution to that. Give that problem to a nurse and a midwife, and they will find all of the workarounds and the ways to open those gates. They are legitimate skills that researchers actively need. So I think it's about valuing the skill set that you bring, even if it's not your ability to wizard up an SPSS or a STATA program on stats at whim. The clinical skills that you have, realizing and valuing those are really important. So joining clinician researcher teams, getting on publications, and I'm really key about this with clinicians, to get on publications, conference abstract, you know, submissions, conference presentations. And why is that important? Because all of those things contribute to you being competitive for a scholarship for a higher degree by research. And so I work with clinicians to not only be engaged in research, but to do the stuff that matters and that gets you competitive for future success for a research career, if that's something that you want. So being brave, you know, it's saying yes to opportunities and working out the way to make it work after you've said yes.
Thank you very much, Zoe. I can very much relate to that, because a lot of my initial projects were quality improvement projects with other multidisciplinary teams and things like that. And I've got to the point where, you know, as Evan said, you get to the point where you need to be able to, you know, to have that evidence. And then I went and did my PhD at 53. So so it's a you know, a journey, and certainly there are questions there about you know, the quality improvement from the audience, and you know, I think you've answered that really well. Thank you.
I think too, though, if you are in an environment or a health service where there's really no one doing anything much, like no clinical improvement stuff, no one's doing big studies, you're somewhere small, or there's just not much of a culture, then enrolling in a research pathway, sort of higher degree, is a way in for someone who really has got nothing around them. So talking to people, going to conferences, sure, but if there's nothing where you work, what's the pathway? Then I think it is sort of finding the right research higher degree pathway for yourself.
That actually
there's
answers one of the
honours
questions.
programs for nurses and midwives, but then also research assistant work. So doing work as clinical trial midwife or clinical trial nurse. So being involved in those opportunities. The honours pathway, is, like you say, Della, a formal pathway, master's philosophy, master's research. There are those formal, but even the courage to even think that you could do that, I think many clinicians lack that. So being brave enough to reach out to an individual like Christine, like Della, like myself, like Kate, like Evan, to say, hey, this is something I might be interested in. And I appreciate that for many clinicians, you have to be brave enough even to reach out to have that conversation. I don't know if I would have in my early clinician career, but I certainly, part of my role is to make myself accessible enough that people know that they can come and, shoot the breeze with me or my team about what might be a good pathway for me.
So one of the questions was around sponsorship opportunities for a midwife and postgraduate programs. So is there any particular, or would that be a general answer for that question?
Depends on what area you're interested in researching, and if there isn't someone in your area that's leading that particular question that you want to answer, then go and find out who is. And the reality is that there are 15 conjoint appointments for midwifery around Australia, so there aren't that many, and there are in the order of 40 professors or associate professors of midwifery in Australia. So again, we know most of them. So asking people like Caroline, asking people like Della, because what Della is not doing, she knows who is researching that. We are still I think people would be surprised that despite being a very big country, we are still quite connected, and we know that, who's doing work on perineal trauma, or who's doing work on models of care and First Nations models, or workforce like Della, So I think, being brave enough to ask, and also if you're topic agnostic, you don't really care what you're researching, you just want to get into research, then also don't be afraid to look outside of your own discipline. So researching with other colleagues, so nurse colleagues or medical colleagues or allied health colleagues is a really important strategy. It doesn't have to be only from your discipline either.
Right, thank you.
I think just quickly, sorry, we shouldn't underscore the opportunity for multidisciplinary research, because particularly in district, even sort of regional hospitals, I guess, and definitely in teaching hospitals, there's always research going on, and usually there are like fellows, those that are and registrars that are looking to specialize. They need to do research projects, and there's ample opportunity there to link in with our medical colleagues, or your physios, or dietitians, allied health, to get involved in different projects. So I think don't always just hold yourself to nursing. There may be other avenues as well.
Yeah, thanks, Evan. My being in safe medication practice, I work closely with pharmacy, and and that's where I did a lot of my quality projects, and with QM pharmacy students. And I actually ended up doing my PhD through the School of Pharmacy, because they were the ones that had the topic knowledge that I was going down. So definitely it is allied health and multidisciplinary is a great way to go. So thank you, thanks for that. So Kate, what's been your biggest challenge or barrier you've faced as a clinician scientist, and how did you overcome it? I mean, you've done quite a lot, in that trauma and emergency service areas, and it must be very, very challenging to be doing research in those areas. What's your biggest challenge or barrier?
I had to think about this. Probably finding a role where you can actually do it all, because I will never give up my clinical because I absolutely love it, and there's nothing I like more than doing a clinical shift and hanging out on the floor and taking the piss with my colleagues and just having fun. And also, it keeps it so real, and it keeps the research questions real. So finding that role was quite challenging, and it is a reunion on this team. I did my PhD at St George Hospital at the same time as Trish and Carolyn, and I feel like a bit of a failure, really, given of looking at their careers and what they've gone on to do, and keeping and staying in a bedside role perhaps has meant that I haven't gone on to the amazing leadership roles that and had such the same influence that they've had. So there are many different pathways in research. So I think the CNC role, but just because you have a CNC role doesn't mean that you can get a lot of research done unless you've got supportive managers. I wanted to try and get more time to do research, so I wanted to go part-time in the CNC role and part-time in an academic role, and it was quite hard to do. I actually got rejected from a number of universities when I applied for positions because they would only take me if I would go full-time into that academic role. So sucked into that university because I've got 3 NHMRC grants now and they missed out on it. But anyway, so there's not giving up in terms of finding people that will take you on, but you actually need to make a case to be able to do that. I also had to apply 3 times to get a job in the Illawarra Shoalhaven as their CNC because, again, they wouldn't take me unless I would do the role full time. So there was a lot of back and forth and negotiating and not giving up. So finding that role, having informal conversations with people before you apply for things so that things are kind of set up for you. There is still a bit of attitude out there about clinicians being in academia. I remember turning up to my scrubs once. In my scrubs, I'd come from St George Hospital. I was working in the trauma service, went over to the University of Sydney, where they had a consultant from Queensland telling us how to do our jobs. And she told me I'd fit in a little bit better if I didn't come to the university in my scrubs. And I'll never forget that. And I will never say anything like that to anybody. So so important to have people that back you, be able to tell the story as to why you should be given that chance to do this role a little bit differently, have evidence, and yeah, it'll work out and it'll be great.
Thank you, Kate.
I think it's really interesting. Sorry,
yes,
Karen, I was just going to say it's so interesting, isn't it? Because so many of us came through the CNC pathway, because it's sort of like people who want to stay as clinicians, but then who also have an interest in changing the system, actually, and having the sort of half and half hospital sort of academic sort of thing. So it's sort of quite a strong theme, actually, probably among us here on the screen.
Oh, it's such a great role, and but it's about being able to quarantine that time as well for that research domain in that role, which you can do. It's about being able to navigate and negotiate that and finding someone else that's done it and taking advice from them if you're having difficulty.
It's also finding, as you said, Kate, the a university that's interested in that type of role, because traditionally, as you said, a lot of universities want academics full time, and it's almost, I think it's changing. I think it is changing, but it's almost frowned upon that an academic does clinical work. Well, if you're doing clinical work, then clearly you're not working hard enough as an academic. That's a common sort of thread sometimes, but yes, it is. I was exactly the same. It took a long time to be able to find that mix between being able to work half time, at the university, and half time at the hospital.
Yeah, so I still have 2 separate jobs. I couldn't. Yeah. So
yeah,
and that's just the way we've made it work. Yeah.
Yeah, exactly. Could I say one thing about barriers to, and I guess facilitators in a way. For me, it was more sort of in my CNC role with advanced practice and sort of pushing, pushing the clinical boundaries, moving from, for us, like, traditional sort of central venous access to going into long-term catheters like tunnel dialysis catheters and implanted ports. We had a lot of resistance from medical staff in us going into that foray, particularly because it was deemed to be like a bit of a turf war, but for us it was really right patient, right line, right time. And I guess what got us over the line to be able to undertake that type of practice was the science. Because we were collecting data all the time, we were able to present our outcomes to the executive, to our medical colleagues, and they had no recourse because we were saying, well, here's our outcomes, where are yours? And they really didn't have a leg to stand on because we were able to show that we actually demonstrated not only equivalence, but in some areas we demonstrated superiority. And so we were then able to develop our clinical practice and move into these sort of areas that were traditionally seen as medical roles.
That's great. Thank you. Thanks, Evan. So Zoe, how important have mentors and collaborators been in shaping your career journey?
Absolutely essential. You can't do it without them. You can be the hardest worker on the planet, but there are only so many doors that hard work opens. And so I cannot highlight that enough. And yeah, it's absolutely critical. It's tricky for our professions, for nursing and for midwifery. You can't be what you can't see. And the type of career that I have created where I am, west of the border, I didn't have anyone to model that on. And yet, I was really keen to see doors opened for our profession, for midwifery and research leadership. And so I had to be very, very brave and look outside of people that I had automatic access to. And one of them is online today. Caroline Homer has been a very, big ladder holder for me and for many, many others. And I'm sure that there are plenty online that would attest to, the leadership and advocacy and mentorship that she and others on this call have provided for many in our professions. They are absolutely critical. And I think, as well as finding mentors, and I think we've already alluded to this in terms of looking for mentors outside of the a place where it might be natural to look. As so obviously I needed a midwifery mentor, but I've also had some equivalent mentors in other disciplines, and others that are researching in very, very different areas, that are equally as helpful and constructive for me as I try and construct a career that I can't model it off anything explicit and direct. I've had to kind of create it and dare to dream that it could look like anything that I choose to pursue it. This all sounds really abstract, and I want to try and bring it back to being a little bit more concrete. But I guess suffice to say that we really are in privileged professions, nursing and midwifery, that are very diverse. And so, the areas of inquiry that we can look at, as broad as the ones represented here just on this, panel, and, where you look for your mentorship is critical. Also, being a good mentee is really important. And I want to speak to all of the generations here today, particularly if there are, those in younger millennial coming through to Alpha and Bravo generations. What mentors expect from a mentee are a little bit different to what the new generations how they think. And I think, it's important to understand the cultural water that your mentor has swum in and how that might influence their mentorship of you. And also for you to reflect on how you are as a mentee, you are the one that is organized and prepared. You do the heavy lifting, you send the invitations, you set the 3 goals for each mentorship session. You really, do the hard work around accessing that mentorship. Working hard and saying yes to opportunities is really how I've got to where I've got to this point. I've now just got to the point where I can be a little bit more strategic and have like a 5-year plan. But I am in my late 40s and have been a clinician for many, many years and have never been one that has had a 5-year plan. I just haven't been able to see that far ahead. Because you can't be what you can't see. But what I have done is work hard and say yes to opportunities. And a mentor of mine has said, say yes to opportunities and work out how you're going to do it later on. And I've followed that advice, and that's really, I haven't, come up stuck yet, because if you say yes to an opportunity that might be just outside of your current skill set, there's no greater motivator for you to go and get those skills than if you know that in 2 weeks' time you're going to have to rock up, pitch up, facilitate this particular session or whatever, and to obviously resource yourself, but to be brave and to do it. So, it gives you, obviously your mentorship gives you exposure to new networks, to new settings, to new skill development that you would not be able to access just out of, hard work alone. And I think another, important, and this is where I'm certainly moving in my current stage of my career, is looking at consumers of our work as mentors as well, really listening to the people that we are engaging, that the services that we're seeking to innovate and to change and to challenge, listening to consumers as a role of mentorship in the way that it guides your, the way that you conduct your research, the humility of listening to the people that your service affects is another form of mentorship that I'd really encourage people to embed at their career from a really early stage. So yes, the mentors that can open gates and doors, but also listening to mentors at all levels and how that can shape and inform the career that you seek to develop as well.
Thanks, Zoe. There's lots of questions online, particularly around working. Nurse. I'm a nurse and I've started my PhD, but I don't have a nurse as one of my supervisors. No, that's fine. So they're going through the medical school, so that's good.
I didn't either. I had an anaesthetist and a statistician as my supervisors.
Yeah, yes. And I think we've answered the questions around whether you need to start with a master's or a PhD before you get involved in research, and I think we've pretty much have answered that yes, get in there and do quality improvement and that leading to those.
Karen, I'd also suggest that that's actually something where a mentor or two would be useful in terms of guiding you, because you could go straight into a PhD. It all depends on your skill set and the project.
Yes, yes.
I'd also add to that don't just do the quality improvement activity, get the dividends from it. So there's a research language and there's research metrics, and they don't mean a lot to clinicians, but they do to the research world. One of the metrics is a publication. So if you do a quality improvement activity as part of your team and there is a publication yield from that, then it should be an expectation that you contribute to that and that you are also a co-author on that. I've seen too many times nurses and midwives being overlooked for those opportunities, although they have contributed substantially to the quality improvement activity, have not actually been included as co-authors. And so I want you all to biohack this system and to be aware, and don't be self-effacing. Oh, don't worry about it. I don't need to do that. Yes, you do. Yes, you do. If you meet the metrics for authorship, then absolutely you should be a co-author on that, because you never know when that is going to be relevant and helpful for you in the future. And it speaks the language of research. And also for CMC type positions, having published, it matters. It absolutely matters. So please be brave and put yourself forward for that if that's offered to you.
Yes.
Zoe, I'd even take it back one step, and that is if you're doing a quality improvement project, quality improvement is research. And I would, if I had to do a quality, if I had my time again and I had to do a quality project, I'd get somebody who had research experience and was an academic from the very beginning to work with me on that quality project, so that it would actually probably be more robust than the usual quality projects. And again, like you say, Zoe, can be useful for capacity building.
Certainly, it was that being authors on those publications for those that actually got me straight to my PhD with the number of papers, or I wouldn't have been able to go straight there as well. So
there are schemes now in New South Wales, and I don't know about other states, that if you're working in a CNC role, because that actually has a research component, you can actually get automatic entry into a PhD at several universities.
That's great information. Thank you.
And that wouldn't apply in Victoria, or most universities here, I don't think, but yeah.
That's interesting too. Yeah. So Della, what opportunities do you see as midwife researchers to influence health policy and healthcare systems?
Well, I think we've got huge potential. If you're doing some research and you're publishing it, and you've got a really important research question, you know, then I think we have huge potential. So, for example, we've done a lot of work on how you provide maternity care, having like your own midwife, and that really changes outcomes for mothers and babies, really improves outcomes. So then sort of doing the initial work, then really sort of advocating with policymakers, with health services and so on, with the findings to help, you know, to get your new what you found into practice. I think it's really hard. I think it's extremely hard to translate evidence into practice, but I think we have enormous potential. In one project we did looking at having your own midwife for First Nations women, we've talked to the government all the time saying, why aren't you funding this? We're talking to health services saying, why aren't you doing this? But in the end, what we did was get ourselves another NHMRC grant to then do more implementation and roll it out further. So I think it's a huge potential, but I think it's hard. You've got to be writing policy briefs, you've got to be writing papers, you've got to be talking to the state government, the federal government, you've got to be at conferences, you've got to be present. So I think we have huge potential. Yeah, really, but you have to sort of keep at it and work with people who know, get to know your local policy people, make sure you're talking with, you know, the people in your hospital who are running the service, whatever area you're in. And like I think everyone said, be a bit brave about how you do that. Just talk to people, ask questions.
Thank you.
It's not easy. It's not eady.
No, it's a lot of engagement, isn't it? Yeah.
Yeah.
Evan, I mean, you've had some effect on clinical standards within Australia with the research that you do. Would you like to speak to that, influencing policy in healthcare?
Yeah, I think there's
It's a bit hard to hear you, Evan.
Yep. Is that better?
Yes.
Yep. I think there's probably two ways. One is you can synthesize the evidence that's out there and then utilize that for local policy, which can then, you know, sort of build capacity to, you know, sort of district policies and guidelines and whatnot. And I guess the other way is to, you know, if you do have a good mentor and you do have a good team, you can find those evidence practice gaps. You can produce the evidence with good science, and that good science then usually replicates into a good publication, which is then taken up by, you know, organizations that produce, you know, national or international guidelines. I mean, one example, I've got a couple of examples. One was the big sort of OMG study that we did, where we reviewed, you know, something like 42,000 cannulas across 52 countries. The data from that's what, when we looked at the outcomes in Australia, they were no better than, you know, sort of third world countries in terms of our outcomes with peripheral catheters. You know, and that started to get the ear of you know, the appropriate authorities, I guess you would say. But then there were others that were also agitating at the time, and we seized the moment, and we were able to then, you know, look at developing a national standard on the care and management, insertion and management of PIVCs. But I guess one local one would be, you know, we found that when we were placing our central lines, whether they be PICs or CVCs, that, you know, we'd put the line in, we'd then get an X-ray, we'd have a look at the position, then we'd release the line for use. But sometimes we'd find that, it'd take forever to get an X-ray, like for the mobile X-ray people to come along, or, you'd get the X-ray back and the catheter was malpositioned, so you had to then somehow manually manipulate it into position. And we knew there was other sort of emerging technologies such as intracavitary ECG, where you basically use the patient's own intrinsic heart rhythm to place the catheter, because you basically hook up the catheter. As long as there's saline in the catheter and a little bit of metal, the tip of the catheter becomes a dynamic ECG dot. So you can actually float the catheter in, and as it heads towards the atrium, the P wave starts to increase in amplitude. And as you're right at the top of the atrium, that's where the cavo-atrial junction is in the SA node. So you get peak to P. So you know exactly where you are, and you don't need any sort of radiological confirmation, but there wasn't much evidence out there around it. So we looked at it. We did a systematic review, meta-analysis. We found that a lot of the studies were quite heterogeneous. So they didn't have enough numbers, and so that the confidence intervals were quite wide. So then we did our own appropriately powered randomized trial. But I got the biostatisticians, the health economists, I got all the experts in to help me develop the protocol, to help me develop the study design. And we conducted the study, and we found that intracavitary ECG was almost exclusively 100% accurate compared to using X-ray. But because I was a clinician scientist and I had my boots in the trenches, yes, we produced the publication, but we almost immediately put it into practice, and we changed policy within our own hospital. But then as we went around and we were talking to others then started to use that publication and other emerging publications that would come out. And then they started to change their policies. And now it's in the New South Wales IVAD policy, it's in the ACI guidelines, etc., that, you don't just have to use X-ray to confirm the position of your catheter. You can use other modalities such intracavitary ECG.
Thank you. That's great. We're getting close to time. I just wanted to say there's a few comments online. One saying that they were, Kate, you were their crit care lecturer and tutor at University of Sydney, and you influenced them and their years in the ED department, and then years as a blood management CNC. So, and I've also published you with, and you were a great mentor. So it's lovely to see people online that are well aware of your roles. There's another
that means more than getting a grant, I have to say.
It does. It does, that you've influenced somebody, exactly, and that's why we're on today to do these, to do these panels and ask these questions to influence and support and mentor people. So there's another one. There's a nurse researcher in Queensland found it incredibly difficult to find support in her role or their role, and that all of your stories are so inspirational today. So I think I best leave that there for Leila or Caroline to finish up. Thank you very much, everybody.
Thank you very much, Karen. That was just wonderful. And a huge thank you to Evan, Zoe, Kate, and Della. I just loved all your pearls of wisdom and breaking barriers, finding pathways, finding your area of passion, collaboration, being brave and bold. And I think many of you talked about solving problems that our system needs, that our patients need, that's going to be better for the workforce. So it's not about us as midwives or nurses, it's about the work that we can do, which I just think is a super important way to think about it. And so huge thank you to you all. Jenny, I'll just get you to put up the last two slides for me, just so that we can do our final thank you. A big thanks to Trish. Thank you for being with us today and for giving us that lovely story of your career and the things that have made a difference. I think people found that really helpful. And also to Christine, I know she's jumped off, but it was lovely to hear her story as well. So the final slide, if we can go to that, is just to say thank you to all of you for joining us. We really appreciate you being with us today and for your questions, which I think were really interesting. Many of them were about how do I make the first step? And so I would suggest you think about a trajectory into research, go and find people. I think Zoe talked very well about finding people to help you. Go and work with people. We're interested in your feedback. We do this kind of session every 2 years, but we're really interested in what it was like for you and what else you would like next time. So a big thank you to Karen, who had the hard job of managing the questions coming in and the people. So terrific job, Karen. Thank you so much. And of course, to all our colleagues at the Academy who made today happen. Thank you, everyone, very much. We will see you maybe next time, and please reach out to colleagues, to friends, and to mentors across the country. All the best. See ya.